Hello everyone. This is a video where we describe step-by-step guide to flexible and navigable suction ureteric access sheath, also called as fans, and how to navigate this in the PCS for RARS. We will also share our initial clinical experience, outcomes, and suggestions on how this may be a potential game changer in RARS. In this video, we also aim to answer a couple of questions. Can fans with suction help reduce the need for re-intervention, ancillary equipment, and improve patient experience? Coming to the OR setup, it is a conventional lithotomy position of the patient with C-arm in place and with both the display monitors positioned according to the convenience of the surgeon. The trolley is positioned close to the patient's left leg in continuity with the sterile zone and with semi-rigid ureteroscopes of both the sizes, that is 6 by 7.6 French and 8 by 9.8 French for initial semi-rigid ureteroscopy. Once in position, we use a semi-rigid ureteroscope to do the ureteroscopy and rule out any ureteric narrowings, strictures, or any anatomical anomalies in the ureter, and also actively dilate the ureteric lumen. The guide wire is positioned in the PCS and is later confirmed by fluoroscopy. There are a few options in the market as far as the suction ureteric access sheath that we have used in this procedure is by name ClearPetra from the company Well-Led, which is 12 French inner diameter and 14 French outer diameter. The length of the access sheath comes in varied options, starting from 35 centimeters to 50 centimeters in length, with clear markings on the sheath and of course with a very good hydrophilic coating. A specially designed oblique side port for negative pressure aspiration or suction, which is controlled through an ergonomically positioned pressure vent or a pinch valve on the side port. The red band marks the limit for the endoscope withdrawal, wherein the suctioned tiny fragments do enter into the pressure vent. The stylet is locked and unlocked using a corkscrew movement, which gives an airtight sealant. The sealing or a rubber cap has an aperture through which the scope is introduced. This ensures that there is no backflow of saline when an endoscope is introduced into the aperture. Coming to the unique feature of this sheath, the flexible tip, we can differentiate the flexible part, which has a corrugated pattern, and the rest of the sheath, which looks smooth. A demonstration of the flexible tip of access sheath with the scope inside the sheath is demonstrated here. Backloading of the guide wire and advancing the access sheath up to the renal pelvis is the next step, and after introducing with minimal force, the stylet is removed along with the guide wire. The next step is to connect the suction tube to the specially designed suction port in the access sheath. The suction tube is connected to the suction machine and in turn to the main vacuum port in the OR. Once connected, the suction is activated in the continuous mode with the pressures at 150 to 200 millimeters mercury. The flexible ureteroscope is introduced through the aperture in the rubber cap with the irrigation on, identify the stone, and then we start the lasing. We have used a thulium fiber laser here with the settings of dusting and fragmentation, wherein the dusting was set at 0.3 joules and 50 Hz, and fragmentation was set at 1 joule and 8 Hz. With these settings, the stone was dusted completely in a fine dust setting and was aspirated intermittently as the surgery was going on. Considering some tiny fragments which are left in the calyx, these tiny fragments were later sucked out with the continuous suction and withdrawal of the scope beyond the red band which we have discussed earlier in the video. So these tiny fragments do come out in a swirling movement when the suction is activated and the scope is withdrawn. The other conventional means of retrieving the stones is by using a basket, which is also possible in this access sheath but is time consuming and can be traumatic as well because of repeated passes into the pelvic alical system. The tip of this flexible access sheath collapses when the suction is activated, but the repeated actions of suction at the tip of this access sheath is atraumatic and is also safe. The suction effect is quite evident in this image where once activated, the renal pelvis collapses. The tiny fragments in the calyces can be targeted and sucked out by positioning the tip of the flexible access sheath in the desired calyx, like you see in the fluoroscopy image where the access sheath is positioned in a desired calyx, and the subsequent series of images here do highlight how sheath is seen with the scope inside and the ones without the scope. So the idea is to target the calyx with the tiny fragments and then introduce the scope to the desired calyx and then move the access sheath to the point of interest and then activate the suction. Once the stone load is cleared, as a part of protocol, a retrograde pyelography was performed at the end of the procedure to rule out any calyceal or pelvic injury, which would be evident in form of extravasation of contrast. A double J stent was placed at the end of the procedure.